because we come from communities where the truth doesn't always reach the headlines, but it lives in what we face every day. This is Changing Trends and Times, bringing clarity and context to the issues shaping our lives right now. No spin, no distractions, just real talk rooted in real impact. Now, are you ready to lean in and bring your voices into the conversation? Then, allow me to introduce to you a man committed to asking the questions that matter and breaking it down so we all understand. Your host, Charles King.
Good afternoon, family. Good afternoon. I want to start today's show off with a Black History reflection of medical apartheid when the system was a disease. To understand why millions of Black Americans walk past clinics without walking in, why they resist vaccines, delay diagnosis, and suffer in silence rather than submit to a system that has historically submitted them to suffering. You have to start at the beginning, not the beginning of their distrust, the beginning of the betrayal. In 1932, the United States Public Health Service launched what it called a study. For 40 years, federal health officials enrolled 399 Black men in Macon County, Alabama, who had been diagnosed with syphilis, and then deliberately withheld treatment from them. Not because the treatment did not exist. Penicillin became widely available in the 1940s. They withheld it because they wanted to watch the disease progress. They wanted to see what syphilis would do to the Black body over time, untreated, undisturbed, uninterrupted by mercy. The Tuskegee syphilis study did not end because of a moral awakening. It ended in 1972 because a whistleblower went to the press. By then, 128 of the men had died of syphilis or its complications. Their wives had been infected. Their children had been born with congenital syphilis. This was not a rogue experiment. This was a federal policy. And Tuskegee was not the beginning. Decades before those men enrolled in Alabama, a physician named Dr. J. Marion Sims, celebrated in medical textbooks as the father of modern gynecology, was performing experimental surgeries on enslaved Black women in the antebellum South. Without anesthesia, he operated on them repeatedly, refining surgical techniques that would ultimately benefit white women who were operated on only after they were sedated. His justification rested on a myth, a scientific fiction, that Black people feel less pain than white people, that their nervous systems are somehow less sensitive, that their suffering counts less. Medical ethicist Harriet Washington documented this history with devastating precision in her landmark work, Medical Apartheid, a term she coined to describe not one incident, but centuries-long architecture of exploitation. The grave robbing of Black cemeteries to supply medical schools with cadavers, the forced sterilization of Black and indigenous women well into the 20th century, the use of Black prisoners as test subjects or pharmaceutical trials. These were not isolated abuses. They were the foundation upon which American medicine was built. And here is the most disturbing part. The myth did not die with Dr. Sims. A 2016 study published in the Proceedings of the National Academy of Sciences found that a significant percentage of medical students and residents still believe falsely that Black patients have higher pain tolerances than whites, and that the belief led them to recommend less pain medication. Black maternal mortality today runs 2 to 3 times higher than that of white women. And this gap persists regardless of income, education, or access to prenatal care. Black women with college degrees die in childbirth at higher rates than white women who never graduated high school. The system is not neutral. It never was. The history of medical apartheid in America is not background noise. It is not a footnote. It is the foundation. If you want to understand why underserved communities distrust the healthcare system, understand why underserved communities distrust the healthcare system today, you must reckon honestly with what that system did to them and what in far too many ways it continues to do. The disease was never just in their bodies. Sometimes the system itself was the disease. Family, as we get into this series, as we talk about healthcare in underserved communities, there are several things that I want you guys to get to know about what's actually taking place. Because what's taking place right now is something that there's a serious problem in the system that it states that it does not matter who it is or what the problem could be. It is the people that they want to experiment with, and they want to make this be one of the worst situations that people can ever deal with. This system is born broken and is broken to this day. And so I wanted to start with this, to give you guys just a bit as to what we're going to be talking about when we talk about healthcare in underserved communities. Okay, America promised healthcare for all, then chose who qualified. Let's start with the number. Black Americans die from preventable diseases, hypertension, diabetes, heart disease, stroke, at significantly higher rates than white Americans. Not because of genetics, not because of some biological predisposition written into their DNA, because of access, because of where they live, what their zip code tells the system about whether their lives are worth investing in, because America made a choice and then called the consequences a coincidence. This country was built on a promise. It is written into the very moral foundation of the American experiment that every person possesses an inalienable right to life. Not life if you can afford it, not life if you live in the right neighborhood, not life if your skin is the right shade or your accent carries the right weight. Life. And if life means anything at all, it means the right to be well, the right to see a doctor, the right to be heard, believed, diagnosed, treated, and sent home whole. The promise has never been equally kept. Healthcare in America has always been distributed along the fault lines of race, class, and geography. Who gets care, who gets a waiting room, who gets a diagnosis, and who gets dismissed, who gets treated, and who gets sent home with a pamphlet and a prayer. These are not accidents. These are outcomes, and outcomes do not happen in a vacuum. They happen in a system. Over the next 4 episodes, we're going to go deep, not shallow, not comfortable, not polite. We're going to look at the data, the real numbers, what do not lie. We are going to hear the stories that policy papers do not capture. We're going to name the structures that have made inequity not just possible, but permanent. And we're going to demand the accountability that underserved communities have always deserved to have and never fully received. Tonight we begin with part one, the foundation, the history, the current reality, because before we can talk about solutions, we have to be honest about the problem, and we have to be willing to say it plainly. If we can name the disease, we can begin the cure, and today we start with the diagnosis. So what we're going to start with is I want you guys to just please follow me, and what I am going to be doing, after this show is I will put some resources on the website. I need you guys to go to the website, Changing Trends and Times. You'll scroll down to the bottom there of the home page, and you will see for the different series that we have that we'll be doing, there will be resources put there per episode. And I suggest that each and every last one of you go and get those episodes, get those resources, because those resources are here for you to not only to have, but to know that when something as to the nature of what we're going through right now in healthcare, we need to make sure that each and every individual can make his or her own decision as to what healthcare looks like to them. So, what we're going to start with, and we talk about the state of healthcare disparities. First, what I want to do is when I talk about underserved communities, I want you guys to know that these aren't my words. This is what America is calling the people that it does not want to serve, but it takes their money. Okay, so according to the CDC, this is how they define underserved communities when we talk about healthcare. They said when they use the term underserved communities, we're not speaking loosely or emotionally. We are invoking a formal designation recognized by both the Center for Disease Control and Prevention and the U.S. Department of Health and Human Services. Underserved communities are those that experience significant, measurable barriers to healthcare access due to race, ethnicity, income level, geographic location, primary language, immigration status, or some combination of these factors. These are communities where the nearest emergency room may be an hour away, where the nearest pharmacy care or physician may have a months-long wait list, where the cost of a single specialist visit can mean a family chooses between healthcare and groceries. The word underserved is not a euphemism for a deficiency on the part of the community. It is an indictment of the system that have excluded them. Underserved does not mean unworthy. It means structural shutout. And that distinction matters enormously in how we understand the problem and design of the solutions. So when we talk about underserved communities and we talk about healthcare, we know that that means that people that, according to the system, can't afford to pay for what they need to get. So, despite having insurance and despite doing what you're supposed to do as a citizen, apparently here in America, healthcare has a truly different designation for what it looks like when it comes to people that are of minority descent. And so to go further into what we were just speaking of when we're talking about underserved communities, let me just tell you guys this, because this is definitely what I just read, what they're actually saying to us is this. It's the indictment for not looking like those doctors that you go to see. So if you have a darker pigmentation, and 9 times out of 10, when you go to your healthcare physician or your doctor's office, you're not going to see people that look like you if you have a darker skin pigmentation. And I was just having this discussion with some people that I talk with a lot when it comes to that, as to why we are seeing this. But I also read this documentation or this story, this article about 2 weeks ago that stated that according to the what happens in the healthcare system, there's a disparagement of doctors that so happen to be of a darker skin pigmentation. That is black, brown, whatever you may be, Asian, whatever have you. That there's a disparagement, to discourage you from actually getting into the industry, and they found ways to cut these people off. So it's like no matter where you go and you looking for good health care, and if you're not trusting because of what has happened to you, 9 times out of 10, that means that your suffering is going to get even worse. Now, I'm not saying that to be to scare anyone or to make people feel any other way than what's real, but this is what is happening. And so they're talking about, because you don't look like them, and that means that you're not only not worthy, but your issues or your medical problems or wherever you're there to be seen, they don't put that to the forefront. Now, I'm sure just like anyone else, we all have had that opportunity that when we've gone to our doctor's office and we're looking for services and we're talking about what is happening with us, there's been a dismissal of what you have actually said to that physician. And I want you to think about that when I say there's been a dismissal, because the dismissal is that when you say you're feeling this way, they dismiss that and they tell you, no, you're feeling this way. And this is what they're going to treat you with or treat you for. They're not treating you for what you're saying is your problem. Now, I'm not sure if you guys, if any of you might feel uncomfortable with that, but I can tell you that I have. And I can tell you that I have because there's been times that I've gone to the doctor's office and not trusting anyway. I really don't trust folk in healthcare, because I'm not saying all, but there's just this thing where I'm just leery, because when I think about what I just read to you guys in the opening of this show, and you have to think about you have to rely on somebody that does not look like you to take care of you. That doesn't make sense. And when I say it doesn't make sense that you have to suffer in this kind of silence because the treatment that you need, you're not getting, but you're being charged for those very same services. This is a common thing that happens. And so, now the reason why this is important when we talk about, when they mention underserved communities, is that we're talking about what could be possibly a life or death situation. And if that's the case, if you have to deal with something like that, that is definitely not the thing that's going to that's going to make you feel comfortable with how things are supposed to work for you. Because if you're thinking about what's going to be best for you, then you know that just having someone to tell you what what you should do or how you should be feeling, and that's not the way you're feeling, you can't be comfortable with that. None of us could be comfortable with that. So I just think that when you want to get a real diagnosis, that's what you go to the emergency rooms or to your doctor's office for. You want to get a real diagnosis. You don't want to get something that they say that you should have, how you should be treated, and then sent home. And you go home and there's no telling what could be the things that could happen to you when you do get home. So, at any rate, this is one of the things that we talk about when we talk about underserved communities and what happens to a lot of people when you do go to doctors. Another point that should be made, and let me just tell you guys about this data, because the data is real, the numbers are real. I've actually checked them 3 to 4 times prior to getting ready and preparing for this series. And I prepare for this because I think these are things that anyone that's living in what they consider an underserved and marginalized community, or if you consider to be one of those persons, then this is something that you just need to know. So the data is damning in key disparities by the numbers. The numbers do not lie, and they do not leave room for comfortable interpretation. Black Americans experience higher rates of hypertension, type 2 diabetes, heart disease, and stroke than their white counterparts. And they die from these conditions at higher rates too. Black maternal mortality in the United States runs 2 to 3 times higher for Blacks than they do for white women. And this gap persists across income brackets and educational attainment. The life expectancy gap between Black and white Americans narrowed briefly in recent decades, but has widened again, a stark indicator that systemic inequalities or inequities are not being resolved, but the redistributed rural American face a compounding crisis. Nearly 60 million people live in areas designated as health professional shortage areas, where there are not enough physicians to meet basic community needs. Hospitals in rural counties have been closing at an alarming rate, taking emergency departments, obstetrician wards, and behavioral health services with them. And Native American communities face some of the highest rates of diabetes, suicide, infant mortality in the entire country. Outcomes directly tied to poverty, geographic isolation, chronic underfunding of the Indian Health Service. And these are 2 coincidences. These are the predictable outcomes of systems that were designed or allowed to exclude. So what is happening here is, again, there's another part to what the inequities have been looking like and what is happening to people when we talk about, just plain and simple, an inequity when it comes to healthcare. So what I want you guys to think about is the Tuskegee experiment. Dr. Sims and the things that he was doing to Black women, from a gynecological perspective, where he was operating on women with no medications to numb the pain or to numb the situation so that they can have these surgeries, and there was forced sterilizations and the broader architecture of the medical apartheid, that took place. And so what's actually alarming about and damning about these disparities is that these are things that people of Black and brown descent can honestly talk about these things, because these things really did happen. And to know that, as in the late 70s, early 80s, when they were doing that sterilization of the Hispanic and Black women in California, that was not that was real. That was not a joke. That actually happened. And with that happening, just think about what was going on when these women were dying. And think about when you have a diagnosis of diabetes and you are, type 2 diabetes, and you're black and brown, Asian, whatever descent you may be, and you're going to your doctor and they take the wrong approach in most cases because they want to tell you that the only way they can that they can actually get you going the right way is they have to give you insulin. They get you insulin dependent, which causes your pancreas to not work. It causes your pancreas to not work. There are other ways, of course, hey, if this is a diagnosis, the diagnosis, but I can tell you, me personally, when I go and I look for a healthcare physician, I want to go and look for someone that looks like me. Because I can look, when I look them up and I see that physician, I am able and I can trust the reliability of what I do when I look up this physician as to his or her credentials, the things they've done, and what they're doing now. I can look them up and I can be comfortable with them. When I go into their office, I can sit there and I can be comfortable with them and have a real conversation. The uncomfortability of someone that's black and brown or whatever other descent that's not actually what they call white, there's an uncomfortability there because these people act as though if they don't understand what you're saying, but you have to understand what they're saying. And they're actually talking totally opposite of what you're telling them. And so this is one of those things that contribute to more and more of what's happening with the negativity when we talk about healthcare and its improprieties when it comes to anybody that's not white. Because you always hear, especially when the news wants to report stories or newspapers want to write up stories, they write up these stories as to what happened to these people, and there's nothing else said about it unless the family does its due diligence to actually do some investigative research and find out what actually happened that caused the death of their loved ones. So the role of the structural racism in healthcare outcomes. In 2021, the American Medical Association formally declared structural racism a public health threat, acknowledging what communities of color have known for generations. Structural racism is not about individual prejudice. It is about the cumulative compounding effect of policies and practices that have over time concentrated poverty in certain communities while concentrating resources in others. Redlining, the mid-20th century central federal policy that denied home loans and insurance to residents of predominantly Black neighborhoods, did not just determine where families could live, it determined the tax base of their schools, the safety of their streets, the quality of their air, and the quality and the proximity of their grocery stores and medical facilities. Communities that were redlined in the 40s and the 50s are in many cases the same communities that are healthcare deserts today. Environmental racism has placed polluting factories, highways, and industrial facilities disproportionately near Black and brown communities, contributing to higher rates of asthma, cancer, and cardiovascular diseases. The wealth gap between Black and white Americans itself, a product of centuries of exclusion from economic opportunity, translates directly into a health gap, because in America, health is not a right. It is for too many people a commodity. And structural racism has ensured that access to the commodity has never been distributed equally. In this case, when you talk about what's happening in our communities, you have these new data centers that they're putting up all over the place. People are not able to breathe because of these data centers. These data centers are being put in places where they're actually sucking up all of your actual utility resources, and you have to endure what they are saying you have to endure. That's not fair, for one thing, because your tax dollars in this case should be where they should be, that is taking care of you and your communities. Instead, your tax dollars are being transitioned over into other communities and taking care of these people, giving them more and more of the resources that you should have in your community. And so what this means, this goes into the political side of that. That is, your representatives are supposed to be there to fight for you, to do more and more for you, but they're not. So now you got to think, who's working for me and who's not working for me? How do I do this for myself? And how do I, or if I should rely on someone else to get me the health care that I need? Because I'm still paying my tax dollars into this system, but not getting the return on my investment. So this is one of those things. I will say this is that when we talk about this mortality rate and what's happening with Black women during childbirth, this has nothing to do with if she's rich or poor. This is just a fact. She could be educated or not. Black women suffer higher in the mortality rates of pregnancies than white women. Not a good thing. Something has to be done about that, and I know that there's been several studies that folk are trying to create and come up with things, ways of trying to actually take care of this. But time is now of the essence. And when I say time is of the essence, is because what's really happening is that people are really getting a lot of us are getting fed up with this. And I can tell you that I myself, which I don't have like an enormous amount of health issues, but it's just knowing the fact of, if it comes down to what could be a critical situation, what would that situation look like for me? This is where we have to make sure that we are actually taking people with us to doctor's appointments, because this is what they did, back in the 40s, 50s, and 60s. Because I know not trusting doctors has been a thing in our community since God knows how long. I know we have grandparents, we have great-grandparents, we have great-great-grandparents that have experienced situations with healthcare that's like some things that probably none of us have ever seen or would ever believe until we actually see it. And when we see it, it catches you off guard, because you just would not think that some of the things that are happening in healthcare are really happening. And I want someone to tell me, when you go to the doctor, tell me about your experience when you have gone to the doctors. Because what we're going to do as we explore this 4-part series, this is episode 1. We're actually going to have people for various segments over these next 3 episodes that are not only going to share their lived experience, but situations pertaining to many things, from like next week's episode, which is mental health. There's advocacy, and there's just the medicinal part in general. There's going to be people here that are going to be talking about those things. And they're going to be talking about those things because it's something that you, Mr. and Mrs. America, you'll be able to see a face that you're going to be able to put to this situation. You're going to see this situation, and you're going to learn from this situation. As we get to this episode here, this is the introductory episode. And I'll talk about the many various things that you're going to actually have the opportunity to deal with. And it's not that you're just dealing with them, they're happening. And so what I did not do, let me go back and let me say, I want to thank each and every individual that's here today, and for the people that are tuning in. I'm glad that you're here, and I appreciate, you're being here and supporting us each and every episode that we do, because we do these episodes because we want to make sure that the people out in the various communities are informed as to what's taking place. And you guys can think of and you can ask, what are some ways and some things that you can do in order to help change these situations? So when we talk about the Black mortality rate, and also when we talk about life expectancy, hypertension, diabetes rates, and rural physician shortages, let me tell you something. Those aren't just things that are just popping up. They didn't just pop up. They've always been. And so because they've always been, that does not mean that we just have to accept this and keep moving. We've got to do something to change this system, because this system is never going to be inclusive to what your needs are and how you can best be served. Because if it hadn't happened over the last 100 years, that means that there may be a few things that may have changed, but they're not of significance where it's making an impact to give you a better, affordable opportunity. So let's talk about these hospital closures and healthcare deserts. And so when we talk about these, we're talking about what's actually happening more so out in rural communities, where people that are living outside cities, outside major metropolitan cities, that have to come maybe 2, 3, 4 hours just to get to a healthcare facility if they can. We're talking about, again, the consequences of what could possibly be life and death. And that shouldn't have to be when we talk about healthcare in America. Supposedly, this is the largest, freest country in the world. But yet, it is the only place where its people cannot afford healthcare, and they are continuously rising in pricing. So, across this country, a quiet epidemic is unfolding, not of a single disease, but of disappearing care. Since 2010, more than 140 rural hospitals have closed their doors, leaving millions of Americans, many of them elderly, low income, and without reliable transportation, without local access to emergency services, obstetric care, or basic diagnostic testing. But this crisis is not limited to rural America. Predominantly Black and Latino neighborhoods in major urban centers, Chicago, New York, Philadelphia, New Orleans, have also experienced significant hospital closures, often driven by the twin pressures of serving high proportions of uninsured patients and the financial calculus of healthcare systems that follow profitability rather than need. The result is what health researchers now call healthcare deserts, geographic areas where residents must travel 60 or more minutes to reach emergency care. In a heart attack, 60 minutes is the difference between life and death. If in a complicated childbirth, 60 minutes is the difference between a mother who goes home and a mother who does not. Healthcare deserts are not a metaphor. They are a death sentence written in policy and enforced by geography. Now, I'm sure that you all get the gist of what that meant. That truly says the one thing that it couldn't be no clearer. Healthcare services are not going to be accessible in a quick way when it comes to Black and Latino areas. Healthcare is a problem. So now you're forced to move to areas that you can afford in order to be close to emergency services. That's not an intention. Well, that's not meant to be that way, but it's intended that way in order to keep those out that that these folk do not want to serve. Why is that way? I cannot tell you. Only those that make these decisions can tell you that. And this is where we have to ask that hard question. Why do I have to travel so far to get to a healthcare service? Why can't we tell these folk that are running these political offices in our local county and state governments, in our cities, if this is the case, and I have to fight and continuously to argue about services that I not only pay for, but I earn as a right because I'm a citizen of the country. Why do I have to keep fighting for these things that are here for me to use naturally? You have to always fight for these services. And I don't think that that is something that many of us want to keep doing and keep doing and keep doing, because the fighting takes so much out of you. It takes so much out of you. So, when we talk about this structural racism function as a public health crisis, let me tell you guys this. This determines how long you live. Because if you're getting healthcare treatment and you're allowed to seek services whenever it's needed, 9 times out of 10, you're going to do well. You're going to live. But if you've got to go miles and miles and miles away, if you got to go miles and miles and miles away just to get healthcare services, then you're bound to be caught up in something that most likely is not going to be fitting. Is this right? No, it's not. Is this a known fact? Yes, it is. Are they going to correct this? It looks like they're not. So we've got to organize a little bit better in order to get things to work the way they are supposed to. And so when we just talk about that, I want all of you all to be doing what has to be done. Let's have a message here from Charlie Hardy. Congratulations on sharing this critical information. We must convince all of our organizations to join hands and collaborate in attacking the problem. We have too many silos. We must stop being territorial. We must have all hands on deck. Charlie E. Hardy, retired university professor, Tuskegee, Alabama. Thank you, Charlie, for joining the show. And you're absolutely right, because this is one of those things that I will say is that despite the silos, we've got to build our communities where our communities will be able to withstand situations like this. You see, where the problem comes in is that there can be many, many folk that mean good and trying to do good, but there's not enough of us. I agree with you that we've got to get these hands together, all hands on deck. We've got to connect and unify in order to build our communities, in order to make a better system. I agree with you 500% on that. We have to do that. And if you actually got some ideas and some suggestions, I want to tell you, I'd love to talk to you about that, but I'd also love to hear those ideas that you have, because they do matter. Because we're not just talking about ourselves, we're talking about all people, all of our people in all of our communities, because all of our communities are really suffering majorly because access for a lot of these things are just not there. And that's not a good thing. That's not something that should be happening, but it's done by design. So that means that with this system, we can stay in the system, but while we're in the system, we need to be building our own system in order to have better health care, so people can be comfortable and know that they can go and see a doctor that is really going to make things better for them. I do agree. Unification is definitely something that needs to happen. I agree with that 500%. Thank you for writing that in the comments, sir. So when we talk about this trust deficit, this is something that has always been there because, I really think for those that might not know or understand, I mean, what would make these people do this experiment with the syphilis on the Tuskegee Airmen, or this man, this gynecologist, doing these things to these women, to prevent them from having babies? That's horrible. That's horrible. But they weren't even held accountable for these things. But just when we think about this, I mean, why should we trust them? But let me tell you this. See, when we talk about the trust deficit, I'm going to tell you why many underserved patients avoid the system. When a Black patient delays seeking care or declines a recommended treatment or distrusts a physician's advice, the instinct in mainstream medicine is often to frame this as patient noncompliance, a failure of behavior, a gap in health literacy, a problem with the individual. That framing is not only wrong, it is an inversion of responsibility. Medical distrust in underserved communities is not irrational, it is historically informed. It is the rationale earned response of communities that were experimented on without consent in Tuskegee, sterilized without knowledge in clinics across the country, dismissed when they reported pain, misdiagnosed when they reported symptoms, and given lesser care at every level of the healthcare encounter. Contemporary research confirms that medical providers, even those with no conscience bias, are less likely to recommend pain medications, diagnostic testing, and specialist referrals to Black patients than to white patients presenting with identical symptoms. Black women reporting being routinely ignored when they describe symptoms that will prompt immediate action in white patients. The trust deficit is real and is rational and is direct measurable cost in delayed diagnosis, advanced disease presentations, and preventable deaths. The systems did not earn this distrust overnight. It will not recover. It will not recover it with a poster and a waiting room. It must be earned back through policy, through practice, through accountability, and through genuine cultural transformation. If any of you have ever gone to the doctor and you've been misdiagnosed, please tell me what your misdiagnosis was. Now I'm gonna tell you something, because this is really crazy, but it's true. I went to the doctor. The doctor misdiagnosed me and said that I had osteoporosis. Now I'm like, osteoporosis? I said, I don't think that's the case. So then I had to go through, and I said, well, let me just go and see what's going on here, because I don't believe this. So they wanted me to go and have this bone density test and all of that other painful stuff that go along with that. When I went to this specialist, the specialist told me, no, that is not the case. This is a misdiagnosis. That in itself, my right hand, that in itself said, no, I'm not dealing with that again. Because if you're misdiagnosing me for this, which is very simple, if you can misdiagnose something like that, and then you come back and want to tell me that I have something else going on, do you think I believe you? No. Would I ever believe you? No. Should I believe you? No. Because when you're misdiagnosing people, that's malpractice. That is malpractice. And so when you're black and brown and you have a misdiagnosis and you got situations like this that are malpractice, your situation is considered totally different than that of a white patient. Because if a white patient has can come up with something that's going to show malpractice, oh, believe me, it's broadcasted everywhere and you can hear with a megaphone. But yes, that happened to me. How many of you have been misdiagnosed with something when you went to the doctor and the doctor was able to look you in the face and tell you that this was wrong? See, after that particular doctor did that, that doctor couldn't look me in the face again. And there was no way I was going to trust him. I'm sorry, there's just no way. Because that right there could have been a life or death situation for me. But this is what happens with our communities. It's widespread, there's a panic, and people really don't know what and how to handle situations like that. And I can tell you, this is not just me, but it's with any of us. With something like this, we can actually find a way to make this work and do what it's supposed to do. But you know, if we do that, then yes, we do this. But we have to find a way to make this system work for us. We have to, because there's too many people that are dying unsensibly, unconscionably for something that should not have happened. When you have a simple diagnosis, and how they're just diagnosing people now with diabetes, you know, and they're just like throwing people in this little thing about diabetes, and they give you all these drugs that are doing you even more harm and causing you all kinds of problems and issues. Now, again, when I say this, I'm just telling you what's out there. I'm just telling you these facts. I'm not telling you not to go to your doctor. I'm not telling you not to seek medical help. That is not what I'm saying. What I'm saying to you is that these things are happening, and if it's happened to you, it's something you really need to look at. And I think most of us that are in black and brown communities can understand exactly what that means. I want you to think about this. Under this political discourse that we have right now in this country, they have now killed the Affordable Health Care Act. By killing the Affordable Health Care Act, how many of us are going to be able to afford health care? That's even with insurance, because now when you go to your healthcare provider, depending upon where you go and what you're going for, premiums are over $100. Most of us that are in the Black and brown and underserved and marginalized communities can't afford that. Why would they want to cut off healthcare here in the freest nation, the largest nation, the richest nation in the world, as is stated to this day? Why are they cutting off healthcare for our people? But other industrialized countries around this world have universal healthcare for all of their people. I ain't making that up, and most of you all already know this. But just saying, putting that question out there. Why are they trying to take healthcare from us? That's definitely not a good thing. And so, what must change? At the policy level, we've got to have a change. But what must change? The solutions are not a mystery. They have been researched, proposed, and in many cases piloted successfully. What has been missing is political will to implement them at a scale. First, every holdout state must expand Medicaid under the Affordable Care Act. 14 states have still not done so. And the communities most harmed by the refusal are disproportionately Black, low income, and rural. Second, federal funding for federally qualified health centers, FQHCs, must be dramatically increased. These community health centers are frequently an only source of primary care in underserved neighborhoods, and they serve patients regardless of their ability to pay. Now, this is talking about these policies that are in place that are being taken away. And, I got to say, for, when we go and we do things, when we think about politics and what the effects are, each and every person that went to vote this last time, you knew what you was voting for. So if you knew what you was voting for, you don't get buyer's remorse. And if you don't get buyer's remorse, then that means that you know the status in which you have put everyone else in, because you were thinking of effects, but effects only for certain people and not all. And now we're all stuck in a situation that's unbeknownst to any of us. So as we get to the end of this show, let me just tell you guys again, I appreciate each and every individual for being here. I appreciate you guys for listening, but also what I'd like for you guys to do, for those of you that have not yet subscribed to this channel, please subscribe to this channel, because every Saturday when we do these episodes for this series, I want you guys to know that each episode is going to bring something different, but it's also going to be thought provocative for you to be able to use your mind and think about the things that are going on in healthcare that you want to make sure people are able to actually watch. So with that being said, I need you guys to subscribe, but I also need you guys to go to the website, changingtrendsandtimes.com. I need you guys to go and pick up those resources, read these for yourself, and learn about what's happening in the healthcare system. So when we come back next week, when we're adding mental health to this for next week, you guys can come, you can ask all your questions. Also, when you get there, if you know somebody that's doing good community work while you're on the website, go ahead and recommend someone as a change maker. We're going to be highlighting change makers on the website for a whole month once everything has been vetted. And so the last thing is that I'm going to close the show with this monologue because it's very important that you guys understand the who, the when, the where, and the how. So we have the diagnosis. Now we need the will to heal. I want to thank you. I mean that sincerely, not as a formality, but as a recognition, because what we talked about today was not easy. It was not comfortable. It was not the kind of conversation you can have with the lights on, low, and the volume down. We looked at history that America has tried very hard to forget, and we looked at the present that too many Americans are still trying to ignore. You stayed with it, that matters. Here's what part one of this series has made undeniably clear. Healthcare in America has never been equally distributed, not at its founding, not in its expansion, not today. That inequality has a face. It is Black, it is brown, it is indigenous, it is rural, it is poor, and it is real. It had a history, one built on deliberate exclusion, deliberate exploitation, and deliberate policy. And it has a name. We do not have to call it bad. We don't have to call it bad luck anymore. We do not have to call it achievement gap or health literacy problems or patient noncompliance. We can call it what it is, a system that chose again and again who deserves to be well and who did not. In part two of this series, we go deeper into one of the most under-examined and overdue conversations in American public health, mental health in underserved communities. The stigma, the silence, the shortage of culturally competent providers, and the staggering unmet need. You will not want to miss it. But before then, take this episode with you, share it, play it at your kitchen table, bring it to your next conversation with your doctor, your city council member, your state representative, because the people with the power to change these systems are counting on your silence. Do not give it to them. This is Changing Trends and Times. The trends are changing because we refuse to accept the times. I'm Charles Zachary King. Keep watching, keep pushing, and keep demanding better. Thank you all for another great show. We will see you guys next Saturday for part two. And you guys have a great, great, and wonderful weekend. Join us tomorrow on CK Stories from the Heart at 3 p.m. Eastern Time. Thank you all, and